Let's start with the background of it. So in 2006, AHA, American Heart Association, defined cardiomyopathies as a heterogeneous group of diseases of the myocardium associated with mechanical or electrical dysfunction that usually, but not invariably, exhibit inappropriate ventricular hypertrophy or dilatation and are due to a variety of causes that frequently are genetic. So cardiomyopathies either are confined to the heart or are a part of generalized systemic process. So they are a heterogeneous group of diseases which involve the myocardium and may have associated mechanical or electrical dysfunction. And they can either be dilated, the ventricle can either be dilated or hypertrophied, or there can be a combination of it. And this can result in electrical or mechanical dysfunction. And cardiomyopathies can be there in isolation, or they can be a part of a generalized systemic process. And this is the WHO classification of cardiomyopathies. Cardiomyopathies are primary and secondary. And primary are those that result from genetic abnormalities of the cardiac muscle. So you can do little about it. So it is in the genetic makeup of an individual. They can be dilated, hypertrophic cardiomyopathy, or restrictive cardiomyopathies. And secondary cardiomyopathies are those that result from infection. For example, HIV cardiomyopathy is there, metabolic and nutritional diseases. There is a cardiomyopathy in diabetes mellitus as well, endocrine, neuromuscular disease, blood disease, and tumors. So, in short, cardiomyopathies are primary and secondary. Primary ones are there in the genetic makeup of the individual, and secondary, they result as a maybe secondary to infections or metabolic and endocrine and metabolic processes. And these are the primary cardiomyopathy, genetic HCM, ARVD. ARVD is arrhythmogenic right ventricular cardiomyopathy or dysplasia. LVNC is left ventricular non-compaction. This is another cardiomyopathy. Then there can be cardiomyopathy with glycogen storage diseases, mitochondrial myopathies, congenital defects, ion channel disease like in Brugada, LQTS, long QT syndromes. Then mixed DCM, restrictive, non-hypertrophic, non-dilated, and acquired in the form of inflammatory, like myocarditis, stress-induced, what we call Takotsubo, peripartum cardiomyopathy, tachycardia-induced cardiomyopathy, and infants of insulin-dependent diabetic mothers. And functional class, dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, and arrhythmogenic right ventricular diseases. So there are n number of cardiomyopathies, but this is the basic classification of it: primary and secondary. These are primary are those that are in the genetic makeup, and every else cardiomyopathy is secondary. And now there is different prognosis of different cardiomyopathies. Dilated cardiomyopathies. The best prognosis is for peripartum cardiomyopathy. This is just for the information purpose. The best prognosis is for peripartum cardiomyopathy, and the worst prognosis is for HIV cardiomyopathy. Now let's talk about dilated cardiomyopathy. Definition: primary, as we just saw, that it is in the genetic makeup. It's a disease of unknown etiology that principally affects the myocardium, leading to LV dilatation and systolic dysfunction. Most common of the cardiomyopathies. These are most common of the cardiomyopathies. Dilates, the conduction system is stretched, so you can anticipate every type of arrhythmia, atrial fibrillation, conduction delays, sudden cardiac death. The prevalence is 36 per lakh population. Third most common cause of heart failure, but the most common cause of cardiomyopathy, dilated cardiomyopathy. Most frequent cause of heart transplantation. Complete recovery is rare, except in certain circumstances. In peripartum cardiomyopathy, 4/5 of the population, 4/5 of the ladies, they recover completely within 6 months. 50% die within 2 years, and 25% survive longer than 5 years. So the prognosis of dilated cardiomyopathy is worse than most of the cancers. Now, before we jump onto the videos, uh, I'll remind you about the quantification, a few slides of the quantification, and then it will become easier for us to label a patient as dilated cardiomyopathy. So this is from the chamber quantification of left heart, American Society of Echocardiography Guidelines 2010. Let me remind you again how we do certain measurements. Left ventricular internal diastole diameter, ventricular internal diameter in diastole and wall thickness are measured at end diastole at the onset of the QRS complex in ECG, and preferably in a frame where the cardiac dimension is the largest. So that will be the frame where, because see, the diagnosis of cardiomyopathy is dependent on the measurements. If we do not perform the measurements accurately, we may mislabel some cases of dilated cardiomyopathy in the initial stages as normal, and vice versa as well. Because this, what we have to do on the echo is we just have to measure various diameters and see if they are out of range, right? So for that, we need to know the correct technique of measuring it, the correct way of measuring the LV dimensions, various LV dimensions. So diastolic dimensions are measured at end diastole, left ventricular internal diameter and wall thickness. At end diastole, at the onset of QRS complex in ECG, but preferably in a frame where cardiac dimension is the largest, right? Then this is the frame of the cardiac cycle where when they are measured. Now the site where they are measured is at the mitral chordae level. I'm sure most of you must be remembering it, but this is just a passing reference. So this is measured. These dimensions are measured at the mitral chordae levels, at the tip of the mitral leaflets, and then the systolic diameters of the left ventricular internal diameter, systole, aortic root diameters, and LA diameters measured in end systole in the frame just preceding mitral valve opening, or in the cardiac cycle in which cardiac dimension is the smallest. So these are the measurements. Now a brief about the values of the of various diameters, because जब हमें values पता होंगे, only then we can label the left ventricle to be dilated or normal, only when we have the normal normative data, when we remember the normal values. So LV internal diameter, systolic dimension 50 plus minus 4 in males, and 45 plus minus 3.6 in females. Similarly, these are the data for systolic dimensions, and I'll tell you a simplified way of remembering it. And then this is about the end diastolic volume, 106 plus minus 22 for males, and 76 plus minus 15 for females. This is the end diastolic volume, and similarly for the LV end systolic volume. Now I'll tell you a simplified way of remembering it. Left ventricular end diastolic diameter, which we measure in the plaques view with M mode cutting through the tips of the mitral leaflets. So this is the normal diameter, 37 to 56. Anything above 56 is abnormal, is dilated for males, and above 53 for females is abnormal. Just remember this much. Just remember this much about the LV, right? About interventricular septum, the normal is 6 to 10. Same for posterior wall, 6 to 10, and 6 to 9 for females, both cases in interventricular septum and posterior wall. right? You must remember this: ventricular and diastolic diameter. 56 is the upper limit for males, and 53 is the upper limit for females, right? And similarly, LA area, mostly not done, but it is the LA volume index which we are supposed to report in our report, we are supposed to write and calculate and present in our reports. It's the LA volume index, which I'll tell you. This is the LA volume index. Normal 16 to 34, males or females. So 34 ml per meter square is the LA volume. This is the up to 34 is normal. Anything above 34 is dilated, right? So you must remember these two only. As far as dilated cardiomyopathies are concerned, LA volume more than 34 ml per meter square, and left ventricular and diastolic volume and diastolic diameter more than 56 in males and more than 53 in females. That's abnormal, right? So having this much information, now let's jump to the cases, right? So can you please unmute yourselves so that we'll try to make it interactive. We'll try to make it a bit interactive. So please unmute yourselves. Right. So this is what is this? Which wave is this?
Long axis view.
This is parasternal long axis view, and you can make it. You can see from a distance that this the LV looks dilated, right?
Dilated. Yeah.
Good. Now this is the short axis view at the level of mitral valve. See, mitral valve. Right. Now this is the short axis view at the level of the papillary muscles.
Papillary muscles.
Now have a look at the short axis at the level of the apex. See, this is not the contractility. The contraction is not as good as it should have been. Now have a look at the fourth chamber. See, LV is dilated for sure, and LV function on the whole, systolic function seems depressed. This is the two chamber view. Again, you can see it is dilated. So this was one. And now let's have a look at the other case. What do you see in this?
Grossly dilated LV.
This is grossly dilated. See, when in the initial stages of the dilated cardiomyopathy, the LV becomes dilated, and as it progressively dilates, it reaches the stage where the shape of the LV becomes globular. It becomes globular, right? The normal blood shape of the LV gets lost. We no longer see a blood-shaped LV, so it becomes globular. That's exactly what happens. See, this is grossly dilated. You can see, right?
Yes.
Can you see this here? This area, this flow, which is almost whitish in cycle. This flow.
Yeah.
It's not that clear, but I'll try to show in our next classes. This is what you call SEC, spontaneous echo contrast. This is the blood which is swirling in LV, but as the LV function seems depressed, very much depressed here, so a sort of stagnation sets in, right? This is called spontaneous echo contrast, and this is the forerunner of LV clot or where in whatever chamber it is. If it is in the LA, this is a forerunner for LA clot. If it is in LV, this is a forerunner for LV clot, right?
Yes.
So spontaneous is called spontaneous attack. Blood जब LV कम contract करता है, blood stagnation के ज्यादा chances होते हैं. So when blood stagnates, the chances of forming clot are higher, right? Now, what do you see? This is a zoomed view at the level of the mitral wall. There is mitral regurgitation, right?
Yes, sir.
There is mitral regurgitation. Again, you can see mitral regurgitation. This is what? Short axis at the level of great vessels. Can you see the aortic wall here?
Yeah.
See how beautifully it is opening. How beautiful description of a tri-leaflet aortic valve it is. Right?
Yes.
This is the mitral valve. Can you see something? Can you comment upon the LV function? See, LV function is depressed, right?
Yes.
Yeah.
LV is not contracting. The cavity doesn't get closed. There is hardly any thickening of the myocardium, and endocardial excursion is almost not there. So this is a grossly depressed LV dysfunction, right?
Yes, severe LV dysfunction.
Severe LV dysfunction, yes, good. Severe LV dysfunction. This is the pulmonary regurgitation. Now this heart in LV, in the dilated cardiomyopathy, in the future stages, in the advanced stages, it becomes globular. See, it is no longer shaped. It is no longer blood shaped. Grossly depressed LV dysfunction, grossly dilated LV, and see this, the depth is 18. अगर हम 15 पे स्टडी कर लेते, 15 की डेप्थ, which is the normal depth, which is the usual depth where we take the echocardiographic examinations, तो अगर हम 15 पे करते ये तो फिर फ्रेम में नहीं आता, तो 18 की डेप्थ पे भी इतना बड़ा लग रहा है ये. Then we can see in the apical 4-chamber view, there is mitral regurgitation. Mitral regurgitation is expected in these patients because the mitral leaflets become tethered because of the dilatation. So this MR is anticipated. Is very much anticipated. This is the flow through the aortic wall, 5-chamber. This is the 2-chamber, grossly depressed LV, grossly depressed LV. And this is
IVC.
Yes,
IVC.
is IVC. Very good. This is IVC. Now see, this is the subcostal image. See, LV. This is grossly dilated and hardly moving. So somebody has, okay. So so this was about the dilated cardiomyopathy. What you have to do is, when you suspect dilated cardiomyopathy, you'll take the measurements. As I have told you, if the measurements are out of range, if the values that I have mentioned to you, the reference standards that are there in the text, in the literature, if they are out of range, then we can suspect. In the echo report, we don't have to write. In the echo report, what we'll write is LA, LV dilated. If LA is also dilated, LA, LV dilated, severe LV dysfunction present, mild to moderate MR, like this. And then in the impression, we will write that the features are suggestive of dilated cardiomyopathy. We can't say that this is dilated cardiomyopathy. Features are suggestive of dilated cardiomyopathy because ultimately, see, echo से हम सिर्फ ये बताएंगे कि likely what is the likelihood of the case, right? We will not put a stamp on the diagnosis on the basis of echo. So we'll say the features, echo features are suggestive of dilated cardiomyopathy. Never make a mistake of writing dilated cardiomyopathy in your final impression. Just write that features are suggestive of dilated cardiomyopathy. You got it?
Yes, sir.
Okay, very good. So now, as we are done with dilated cardiomyopathy, now we will talk about hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy in itself is a vast subject. It's a vast subject. और बहुत बहुत important subject है. और the presentation of hypertrophic cardiomyopathy are myriad. मतलब it can be a concentric hypertrophic cardiomyopathy. It can be apical cardiomyopathy. It can be obstructive, non-obstructive. Then you will have difficulties in differentiating hypertrophic cardiomyopathy from hypertensive cardiomyopathy, hypertrophic cardiomyopathy from athlete heart. So I'll try my best to cover hypertrophic cardiomyopathy in its entirety and tell you some differences and some the difficulties you'll face. So please mute yourselves, and I'll let you know when to unmute yourselves. Then we'll try to make it more interactive. Okay. Now, hypertrophic cardiomyopathy. This book. This is Advances in Clinical Cardiovascular Imaging, Echocardiography and Interventions, ACCI-EI. This is a textbook of cardiology by H.K. Chopra, Naveen C. Nanda, and Jagat Narola. ठीक है? This book got published in 2020, and this costs 7,600 rupees in the market, right? We have contributed a chapter in it. We have contributed a chapter in it of जो हमारा टॉपिक है आज का hypertrophic cardiomyopathy, उसका एक चैप्टर हमने कंट्रीब्यूट किया है. You can see hypertrophic obstructive cardiomyopathy, advances in echocardiographic navigation in hypertrophic cardiomyopathy. This was from the Max Hospital. We contributed this chapter. See, Dr. Rahul Mehrotra, myself, Dr. Rajkumar, and Dr. Bharat Bansal. So this is one of my favorite topics, and we were fortunate to have our chapter find a place in this textbook. This is a textbook of cardiology, so it's not a mean achievement. It's not a mean feat to have your chapter, if your chapter finds a place in a textbook. So it's not a mean feat. Now, about the hypertrophic cardiomyopathy, we'll try to understand it in the best possible way, and I have prepared this presentation in a manner so that you people will understand the background, you people will understand the nuances of it and the echo diagnosis. Now, you must have heard in sports, in professional sports, usually in football or basketball players, that 17-year-old male professional basketball player with no known past medical history collapses on the playing floor during practice and subsequently arrests. He had been having some exertional dyspnea for a few months prior to the incident, but it did not affect his activity level. He was told growing up that he had a murmur that was never formally investigated. He was taking no medication, and there was no family history of cardiac disease in his family. An autopsy later revealed that the patient had hypertrophic cardiomyopathy. See, हमारे setup में, in our country and in Southeast Asia, जो main problem यहाँ पे है, if a young adult arrests, has a sudden cardiac death, so hardly autopsies are performed so that we could have derived information क्या क्या मतलब Dr. Pratibha, please mute yourself. हाँ कि what exactly was the reason? तो बाहर की वेस्ट में they perform autopsies and later come and then come to a conclusion कि what could have been the possible cause. So this is the irony in our setup. But you must have heard about these instances that young players, football players, basketball players collapsed on the ground, could not be they arrested, could not be revived, and had sudden cardiac death. This is the most common presentation with hypertrophic cardiomyopathy, hypertrophic obstructive cardiomyopathies. So hypertrophic cardiomyopathy is a genetic disorder, type A cardiomyopathy, right? That is typically inherited. But before hypertrophic cardiomyopathy, अच्छा हाँ, dilated cardiomyopathy में there are stages of progression of the dilated cardiomyopathy. ठीक है? As we saw in the etiology that the causes can be myriad. So most common presentation is heart failure. The drugs for the dilated cardiomyopathy are those which are used in heart failure, like ARBs, ACE inhibitors, mineralocorticoid receptor antagonists, then beta blockers, then guidelines में SGLT2 inhibitor, dapagliflozin वगैरह. So those are the usual treatment modules, treatment drugs that are available as that's called GDMT, guideline directed medical therapy for heart failure. And when these patients progress, advance, when there is dilatation and there is depression in the LV function, these patients of dilated cardiomyopathy are prone to arrhythmias, ventricular fibrillation, ventricular tachycardias, and certain cardiac deaths. So in these patients, dilated cardiomyopathy with LV dysfunction, LV EF less than 30%, those are candidates for AICDs, right? Prophylactic AICDs, implantable cardioverter defibrillator. So these are the DCMP, severe LV dysfunction, most common. This setup of population is the most common indication for ICDs, implantable cardioverter defibrillators. Okay. So now about the hypertrophic cardiomyopathy, it's a genetic disorder that is typically inherited in an autosomal dominant fashion with variable penetrance and variable expressivity. The disease has complex symptomatology and potentially devastating consequences for patients and their families. And this is the leading cause of sudden cardiac death in pre-adolescent and adolescent children. So this you must remember, this is the most common cause of sudden cardiac death in adolescent and pre-adolescent children. The hallmark of the disorder is myocardial hypertrophy, as the name suggests, that is inappropriate, often asymmetrical, occurs in the absence of an obvious inciting hypertrophic stimulus. See, hypertrophy usually is reactionary, right? Hypertension है किसी को, LV has to force against a pressure, तो LV has to hypertrophy. तो hypertensive patients में LV hypertrophy is common, right? Which is understandable and which is commensurate with the pressure duration. Second, aortic stenosis है किसी को, LV has to pump against a closed wall, against a stenotic wall, तो again LV has to hypertrophy. तो ये settings हैं जिसमें the hypertrophy is expected because LV has to contract forcefully against a closed against a stenotic wall. That is where we have obvious inciting stimuli like hypertension or aortic stenosis. There we can understand and anticipate hypertrophy. But here in hypertrophic cardiomyopathy, the hypertrophy is the hypertrophy is inappropriate. There are no inciting stimuli. there is no hypertension, no aortic stenosis, and uh, even then there is hypertrophy. So this is what I mean to say is that the hypertrophy is unexplained, right? This hypertrophy can occur in any region of the left. As I told you that there can be multiple presentations of the hypertrophic cardiomyopathy. Hypertrophy can occur in any region of the left ventricle, but frequently involves the interventricular septum, which results in an obstruction of flow through LVOT. We will understand about it. The background prevalence of HCM is 0.05 to 0.2% of the population, but this occurrence is higher than previously thought, suggesting a large number of affected but undiagnosed people. That's true. That's very true. The prevalence of HCM is more than this. Morphological evidence of disease is found by echocardiography in approximately 25% of first degree relatives. अच्छा, any patient, मैं इसलिए बता रहा था कि वेस्ट में जब autopsy होती है, if they find a hypertrophied heart, then they will check for the check in the first degree relatives, ठीक है? So that at least there has been a sudden cardiac death in the family, at least those members who are at risk, who are having the same risk, they are identified, and preemptive measures can be taken in those patients. So this is the beauty of the autopsy in these patients. This is the beauty of associating the cause with the certain cardiac death, so that other people can get benefited, because this runs in the families. ठीक है, अगर मान लो सडन कार्डियक डेथ हुई है फैमिली में, ऑटोप्सी नहीं हुई है, तो हाउ कम वी विल कम टू नो कि इसमें हाइपरट्रॉफिक कार्डियोमायोपैथी थी, और अदर फैमिली मेंबर्स कैन आल्सो बी अफेक्टेड. सो this serves as the basis of the literature. 25% of first degree relatives में HCM होता है. Men and African American affected by almost 2:1 ratio over women and Caucasians. Global disease with most cases reported from USA, Canada, Western Europe, Israel and Asia. India में भी बड़ा खासा चंक लोड है इसका हाइपरट्रॉफिक कार्डियोमायोपैथी का. Historical perspective. HCM was initially described by Thierry in 1958, but this was identified in the autopsy. The first diagnosis was made by Eugene Braunwald, जिसकी text book हम पढ़ते हैं. Eugene Braunwald was the first diagnosed HCM clinically in the 1960s. There are many names. From time to time, there are many names given to it, like idiopathic hypertrophic subaortic stenosis, muscular subaortic stenosis, hypertrophic obstructive. But current nomenclature is hypertrophic cardiomyopathy or hypertrophic cardiomyopathy के फिर subsets हैं, types हैं. ठीक है? It is HCM right now, not HOCM. HCM is hypertrophic cardiomyopathy and HOCM is one of the variants of it, right? You must understand the difference. HCM is the broader term. Hypertrophic cardiomyopathy encompasses the whole term. Then there can be HOCM. Then can be concentric variant of the HCM. Then there can be apical HCM. ठीक है? So these are the patterns of the HCM. This is hypertrophic cardiomyopathy. See, septum is hypertrophied. Herein it is the apical hypertrophy, right? Here septum is hypertrophy, here septum is hypertrophied, and there is obstruction as well. See, this is the mitral wall, anterior AML, anterior mitral leaflet, which comes in contact with the septum in systole, and what you call SAM, systolic anterior motion of the mitral leaflet. ASH is asymmetrical septal hypertrophy. Asymmetrical septal hypertrophy means the hypertrophy in the septum is more than in the posterior wall. Posterior wall के comparison में septum ज़्यादा hypertrophied है. ठीक है? Now this ASH, this hypertrophic cardiomyopathy can have obstruction, as in here, and no obstruction, as in here. I'll tell you. I'll make you understand it very beautifully. the obstructive cardiomyopathy and non-obstructive cardiomyopathy, right? And this is symmetric. See, हर जगह hypertrophied, हर जगह hypertrophied. Every part of the LV is hypertrophied and equally hypertrophied. Pathophysiology of hypertensive hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy involves 4 interrelated processes. Left ventricular outflow obstruction. Okay, there can be, it's not necessarily present in every case, left ventricular outflow obstruction, but there can be left ventricular outflow obstruction as in HOCM. Diastolic dysfunction is the main thing in hypertrophic cardiomyopathy, क्योंकि hypertrophy है heart की, तो systolic function will always be higher. It will be supranormal systolic function. Systolic function will be supranormal. इनमें EF 75-80% भी होता है. There can be myocardial ischemia. Why myocardial ischemia? Because LV की मसल ज्यादा है, ठीक है, तो डिमांड ज्यादा होगी. सो डिमांड सप्लाई मिसमैच होता है इसमें. एंड mitral regurgitation in certain subsets of the patients, like in HOCM, mitral regurgitation होता है. Mitral regurgitation क्यों होता है, उसका भी रीजन है, because of unusual location of the papillary muscle. And I'll tell you that I'll explain this hypertrophic cardiomyopathy to you in a beautiful way. I'll try to present in a beautiful way so that you'll remember it for ages, and you'll be able to accepted nomenclature, use an accepted nomenclature, and there shouldn't be confusion between HCM and HOCM and other variants of the HCM, right? So first thing is left ventricular outflow obstruction. Left ventricular outflow obstruction HCM. अगर obstruction होता है HCM में, LVOT obstruction अगर होता है, left ventricular outflow tract obstruction अगर होता है, तो that variant is called obstructive HCM, right? HOCM बोलते हैं इसको. तो obstruction होता क्यों है? Explanations of the SAM. Obstruction होता है because of systolic anterior motion of the mitral leaflet. Systolic anterior motion of the mitral leaflet against the septum. ठीक है? I'll show that in the images. An explanation of the SAM of the mitral valve. Mitral valve is pulled against the septum by contract. There is actually abnormal location of the papillary muscle, so that mitral valve is pulled against the septum by the contraction, which occurs because of the valve's abnormal position and septal hypertrophy altering the orientation of the capillary muscles. I'll tell you how to diagnose it. Mitral valve is pushed against the septum because of its abnormal position of the outflow tract, and mitral valve is drawn towards the septum because of the low pressure that occurs as blood is ejected at high speed through a narrowed outflow tract. Which effect? I'll tell you. See, this is the parasternal long axis view. Put an M mode across it. This is anterior mitral leaflet. This is anterior mitral leaflet. This is anterior mitral leaflet. Okay? Yeah. You can see here the anterior mitral leaflet is making contact with the septum in systole. यहाँ तक systole है, ठीक है? यहाँ the stage from here to here is systole, and in systole this anterior mitral leaflet is making contact with the septum. This is what you call SAM, systolic anterior motion of the mitral leaflet. Systolic anterior motion of the mitral leaflet. Again in the systole this is making a contact. Again in the systole this is making contact. This is what you call systolic anterior motion of the anterior mitral leaflet, which is called SAM, and this is the basis for obstruction. This is the basis for obstruction. देखिए systolic and systole में ये जो AMN है ये contact करेगा septum के साथ. Systole में LV को blood push करना होता है, कहाँ से? Through aortic valve. अब जब ये यहाँ पे ये बंद है, तो how will blood go out of the aortic valve? नहीं जा पाएगा, क्योंकि ये तो यहाँ पे obstruct हुआ, ठीक है? जितना जाएगा वो बड़ी हाई स्पीड से जाएगा, यहां से बहुत हाई स्पीड से जाएगा वो, ठीक है। एंड बिकॉज ऑफ दिस abnormal this occurs because of abnormal position of the uh, of the of the papillary muscle, ठीक है। the anterior mitral leaflet gets pushed towards septum, और जब ये पुश होता है towards septum during systole, some of the blood regurgitates back into the LA, ठीक है। mitral regurgitation इसलिए इसे होता है, इसमें mitral regurgitation इसमें होता है, systolic anterior motion of the mitral valve which you call SAM, ठीक है। this is the reason for the SAM. अब LVOT obstruction से क्या होगा? there will be elevated intraventricular pressures, prolongation of ventricular relaxation, increased myocardial wall stress, demand supply mismatch हो सकती है, increase oxygen demand and decrease in forward cardiac output, definitely which is expected. obstruction है तो जाएगा कहां से blood? Now this is a graph showing the difference between obstructive and non-obstructive HCM and the freedom for HCM related deaths. Now this blue panel is no obstruction and this is obstruction, ठीक है। only 70%, only 70 to 75% patients with obstruction in the advanced after 10 years of this obstruction, only 70 to 75% of these patients have freedom for HCM related deaths. However, in case of non-obstruction, the freedom is somewhere around 90%. So now from in this graph, you can clearly see that obstructive HCM has a much worse prognosis than the non-obstructive HCM. पैथोफिजियोलॉजी तो हमने देख ली, लेफ्ट वेंट्रिकुलर आउटफ्लो ऑब्स्ट्रक्शन था। अच्छा, ये 4 पैरामीटर्स है लेफ्ट वेंट्रिकुलर आउटफ्लो ऑब्स्ट्रक्शन स्टैम की वजह से। डायस्टोलिक डिसफंक्शन होगा, डेफिनेटली डायस्टोलिक डिसफंक्शन, क्योंकि एलवी मसल मास बहुत ज्यादा है रिलैक्स करने को, मतलब इट विल बी रिजिड एंड इट वोंट बी रिलैक्सिंग द वे इट शुड। myocardial ischemia hoga, as I told you, because of increased muscle mass there will be more oxygen demand and there will be demand supply mismatch, and mitral regurgitation because of abnormal position of the papillary muscles, and because of the SAM blood there is regurgitation of blood back into the LA, resulting in mitral regurgitation. Now what is the clinical presentation of HCM? dyspnea on exertion, ठीक है, because of mitral regurgitation होगा, LA प्रेशर ज्यादा होगी, pulmonary venous congestion होगी, ठीक है, orthopnea होगा, PND होगा, palpitations, any of the arrhythmia is possible, premature atrial contraction, premature ventricular contraction, sinus pauses, atrial fibrillation, atrial flutter, supraventricular tachycardia, ventricular tachycardia, congestive heart failure, secondary to increased filling pressures in myocardial ischemia, congestive heart failure with angina होगा because of demand supply mismatch, क्योंकि requirement ज्यादा होगी, exertion ही नहीं। इसीलिए जो ये एथलीट्स होते हैं इनमें सडन कार्डियक डेथ होता है। क्यों? क्योंकि ड्यूरिंग एक्सर्शन पहले ही हार्ट हाइपरट्रॉफीड है उनका, दोज एथलीट्स हु हैव हाइपरट्रॉफिक कार्डियक, पहले ही द रिक्वायरमेंट ऑफ द हार्ट इज वेरी हाई, और जब वो एक्सर्ट करते हैं तब तो और ज्यादा रिक्वायरमेंट रहती है। So that is the reason these patients have angina and sudden cardiac deaths. Syncope, pre-syncope can be there. Outflow obstruction worsens with increased contractility during exertional activities, resulting in decrease in cardiac output. This is what I was telling you. And secondary to arrhythmias. Clinical presentation: sudden cardiac death. HCM is most common cause of sudden cardiac death in young people, including athletes. Can be the first. अच्छा, इसमें सबसे बड़ा तो इशू यही है कि it can be the first manifestation. Sudden cardiac death may be the first manifestation. Now, what good we can do about those athletes who have underwent sudden cardiac death? Now, the thing we can do is we can perform autopsies, and at least we can see the first degree relatives. Most common causes arrhythmia, especially VF. either de novo or AF degenerated into ventricular fibrillation through the accessory pathways. ठीक है. Now there are some maneuvers. देखिए इसमें भी ऑब्स्ट्रक्शन होता है, HCM में भी ऑब्स्ट्रक्शन होता है, एओर्टिक स्टेनोसिस में भी ऑब्स्ट्रक्शन होता है. Just try to understand the difference. In aortic stenosis, the obstruction is fixed, right? It is fixed. However, in HCM, the gradient is dynamic. It's a dynamic gradient. Now, मैं आपको clinical examination पे there will be a systolic murmur, ejection systolic murmur. AS में भी होगी और HCM में भी होगी. Now, how do we differentiate this? ठीक है. पहले तो we'll see the age group. AS is usually calcific, degenerative stuff found in 50s, 60s. ठीक है. इसमें young age group होगा. ठीक है. एक तो वो suspicion arise करेगा. And the definitive thing is कि जो AS में the gradient is fixed. It is a fixed obstruction. ठीक है. यहाँ पे it is dynamic. We can ask the patient to do certain maneuvers like Valsalva. Valsalva is, we'll ask the patient to strain against the closed glottis. ये बंद करके we'll ask the patient to strain and we'll look for the murmur. It will definitely increase. ठीक है. The murmur will increase because of decreased LV cavity pre and after load. Okay. Valsalva में during strain phase venous return कम होता है. ठीक है. जितना venous return कम होगा, जितना LV में कम ब्लड आएगा, उतना ज्यादा चांस है सेप्टम और एंटीरियर माइटल लीफलेट के चिपकने के. ठीक है. उतना ज्यादा ग्रेडियंट बढ़ेगा. ठीक है. स्टैंडिंग से भी बढ़ेगा. अगेन venous return कम होगा. पोस्ट PVC अगेन it will be increased. स्क्वाटिंग में डिक्रीज होगा. क्यों? स्क्वाटिंग में जितना ब्लड इसमें आएगा, जितना ब्लड इसमें LV में ज्यादा आएगा, उतना ज्यादा डिस्टेंस रहेगा, उतना ज्यादा सेपरेशन रहेगा between the anterior mitral leaflet and septum. So this is the reason जो डायरेटिक्स हैं बहुत कॉशियसली देने होते हैं HCM पेशेंट्स में. इनफैक्ट HCM पेशेंट्स में बहुत कॉशियसली देने होते हैं. They can precipitate obstruction. They can very much precipitate obstruction because they decrease the preload. LV cavity में कम रहेगा volume, तो the chances of sticking together of AML and septum are very higher, and they can stick together for longer times. So that's the reason that diuretics have to be given cautiously in these patients. Now this is the typical electrocardiogram in HCM. See, LV hypertrophy, LV is hypertrophied. See the T inversions. This is the strain pattern, right? This is inverse check mark sign. So this is LV hypertrophy with strain pattern and left axis deviation. One AVF, you have a look at one AVF. So this is left axis deviation. Okay. Now you can have a look at the P wave in V1. It is LAE. See, terminal half of the P is more negative. So this is LAE. This is what you call left atrial enlargement, increased P terminal forces और Morris index को बोलते हैं. ठीक है जी? तो ये है. Now, this is a slide to show the difference between HCM athlete heart. See, those athletes have hypertrophied heart. Athletes have hypertrophied hearts, but it's not necessary that they're having HCM. Now, how do we differentiate between these? HCM can be asymmetric. Athlete's heart is concentric, and it regresses. ठीक है जी. Wall thickness HCM is more than 15 mm. यहाँ पे 15 mm से कम होता है. LA dilated होता है HCM में, यहाँ पे कभी dilated नहीं होगा. एथलीट हार्ट में अगर डायलेट होगा then the diagnosis of athlete heart on echocardiography is in question. लेफ्ट वेंट्रिकुलर एंड डायस्टोलिक डायमीटर 45 से कम होगा HCM में, यहाँ 45 से ज्यादा होगा, ठीक है। यहाँ पे कैविटी साइज कम होती है, तो यहाँ पे हाइपरट्रॉफी भी होती है, हार्ट भी कमेंसरेट होता है उसके साथ। डायस्टोलिक डिस्फंक्शन विल ऑलवेज बी एबनॉर्मल इन HCM, इट विल ऑलवेज बी नॉर्मल। देखिए एथलीट, अगर आपको डाउट हो रहा है एथलीट हार्ट इको पे, आप हाइपरट्रॉफी देख रहे हैं यंग एडल्ट में, ठीक है, it can be it can be athlete heart, it can be HCM. Now how do we differentiate between these? डायस्टोलिक डिस्फंक्शन होगा तो ये 100% HCM है, ठीक है। LA डायलेटेड होगा तो 100% HCM है, और लेफ्ट वेंट्रिकुलर एंड डायस्टोलिक डायमीटर 45 से कम होगा तो ये that's a pointer towards HCM, ठीक है। Now these are the variants of HCM. This is सबएयोटिक, ठीक है, सबएयोटिक हाइपरट्रॉफी इस सेप्टम में, सबएयोटिक हाइपरट्रॉफी है, यहाँ पे अपाइकल हाइपरट्रॉफी है, यहाँ पे डिफ्यूज है, और यहाँ पे मिड वेंट्रिकुलर हाइपरट्रॉफी है। I'll show you each one of these variants. Asymmetrical septal hypertrophy. When do you call septal hypertrophy asymmetrical? Unexplained maximal wall thickness more than 50 millimeter in any myocardial segment, or this is what you call ASH, asymmetrical septal hypertrophy. Septal posterior wall thickness ratio greater than 1.3 in normotensive patients, or septal posterior wall thickness ratio greater than 1.5 in hypertensive patients. ये देखिए, now this is the M mode across LV, ठीक है जी। now ये तो मैंने पहले ही बताया आपको, this is SAM. AML देखो कैसे चिपका हुआ है सिस्टली में इसके साथ। now just have a look at the septum, the thickness of the septum and thickness of the posterior wall. This septum is almost double than that of the Dr. Milind Diol, please म्यूट कर लीजिए अपने आप को प्लीज। हाँ जी, तो the thickness of the septum is almost double than that of the posterior wall. This is the typical asymmetrical septal hypertrophy. Asymmetrical septal hypertrophy में septum posterior wall ratio should be more than 1.3 in normotensives, and in hypertensives it should be more than 1.5, ठीक है। So this is again, see the thickness here is way more than the thickness of posterior wall, and see the SAM. This is ASH and SAM. Now pathophysiology of HCM dynamic. The LV outflow tract obstruction is dynamic. It is dynamic, ठीक है, it's not fixed as in AS. Diastolic dysfunction, myocardial ischemia, myocardial regurgitation, and this hypertrophic cardiomyopathy, asymmetric septal hypertrophy, cavity size will be reduced, and mitral valve में ये, this is the non-obstructive hypertrophic cardiomyopathy, mitral valve in normal position. In obstructive pattern, this is abnormal location of the mitral valve because of the papillary muscle, because of the abnormal location of the papillary muscle. See, the septum is hypertrophied, AML is pushed towards the septum, resulting in SAM, which then results in the gradient hypertrophy, this obstructive gradient, and which in turn results in mitral regurgitation, right? Now, this video shows parasternal long axis view. You can see the LV is hypertrophied, very much hypertrophied, and you can see this is the AML. AML is pushed towards the septum, and this results in a mosaic flow, turbulent flow here at the site of contact. And this is the first sign of SAM. See, you can see how hypertrophied it is, and see the contraction of the LV. This is supranormal systolic function. See how hypertrophied this is. Now, this is the gradient I was talking about. This obstruction leads to a gradient. See, this gradient is almost, the pressure gradient is 4V max square. This is almost 3.5. So this is around 46. See, I'll talk to you about the gradient separately. This is, see, this is a two-chamber view. See how the cavity is almost obliterated. This is the apical three-chamber view, color compare view. See the, ये जो यहाँ पे ये turbulent flow है, which is not laminar flow. This occurs because of the SAM. Now, see this gradient here. This is the LVOT gradient. We have put the continuous wave Doppler across the LVOT, and now, अगर आप देखेंगे, this is dagger shaped. This is absolutely dagger shaped. मैंने आपको शायद PS में जो केस रिपोर्ट थी, वो सब वेल्वुलर PS का वो दिखाया था मैंने आपको. तो this is the dagger shaped continuous wave Doppler profile in the LVOT. This is how the gradient of in an HOCM looks like. Typical presentation. अब कितना है? 3.65 meters per second or 365 centimeters per second, and the maximal pressure gradient is 53. If it is more than 50, then I'll show you the chart about it. So you have to put the point on the maximal point of this dagger shaped profile. The machine will calculate the maximal PG. So this is 53, right? ASH, SAM, and gradient. That confirms the diagnosis of HOCM. Okay. Now I'll show you another case of HOCM, obstructive. अब please ये आप समझ लें. This is obstructive. Obstructive. HOCM is obstructive. See this. Now if we stop it somewhere, you can clearly see this anterior mitral leaflet is making a contact with the septum here. This is what you call SAM. It's making a contact with the septum in systole. This is what you call SAM. Yes, it is making a contact with the septum. Now this SAM is resulting in a turbulent flow here. See, you can easily see the turbulent flow here. This is a very turbulent. This is not a laminar flow, right? अब इस SAM की वजह से turbulent flow आएगा, gradient फिर उसी की वजह से, then we'll get a gradient because of that. See the short axis view में कितना hypertrophied है. See how hypertrophied it is. अच्छा, ये जो ऊपर आप देख रहे हैं ना एक बैंड, बस ये तो, दिस इज बाय द वे आई एम टेलिंग यू, ऊपर जो बैंड दिख रहा है ये, दिस इज कॉल्ड द फॉल्स टेंडन. दिस इज द फॉल्स टेंडन ना, ऐसी, just for the sake of information. See how hypertrophied it is. This is the 5-chamber view. Again, you can see the turbulence here and a bit of AR. Now, जब भी हम AS का हम प्रोफाइल लेते हैं, that is rounded. The profile, continuous wave profile of the AS is rounded. See here, it is again dagger shaped. ठीक है, continuous wave Doppler across LVOT. See, this is dagger shaped. जो maximal velocity है 4.67 meter per second, and the pressure, maximal pressure gradient is 87, which is way higher. See how beautiful. हाँ, ऊपर देख लें आप, ये this is the false tendon. The false tendon. Now I'll tell you about the gradient, the pressure gradient which we just reported. I'll tell you the significance of it. If you come across a patient of suspected of HOCM, ठीक है, आप एकोकार्डियोग्राफी कर रहे हैं, ठीक है, उसमें LVOTO, लेफ्ट वेंट्रिकुलर आउटफ्लो ट्रैक्ट ऑब्स्ट्रक्शन, जो पीक ग्रेडियंट है, ठीक है, इफ इट इज मोर देन और इक्वल टू 50 मिलीमीटर ऑफ मर्करी, ठीक है, तो दिस पेशेंट नीड्स टू बी ट्रीटेड ऑन द लाइंस ऑफ HOCM. HOCM में क्या ट्रीटमेंट है? माइमेक्टमी ट्रीटमेंट है, उसमें अल्कोहल सेप्टल एब्लेशन है, ठीक है, दोज आर द ट्रीटमेंट मोडालिटीज अवेलेबल, ठीक है. सो दिस नीड्स टू बी ट्रीटेड लाइक दैट इफ इट इज मोर देन 50. नाउ अगर मैक्सिमल प्रोवोक्ड पीक LVOTO is less than 50, if he is asymptomatic, then he needs to undergo echocardiography annually, ठीक है, periodic echocardiography, periodic annual echocardiography, if he is asymptomatic and gradient is less than 50, maximum gradient is less than 50. But if he is symptomatic, then exercise stress echocardiography करनी है. मैक्सिमल LVOT प्रोवोक्ड अगर मोर देन 50 है तो इसकी तरह ट्रीट करना है, जैसे सेप्टल एब्लेशन होगी, माइमेक्टमी होगी. और अगर सिम्टोमेटिक है बट स्ट्रेस एक्सरसाइज पे LVOTO is less than 50, then medical therapy like beta blockers, maximal dose of beta blockers should be given. This was just about the gradient. ठीक है जी. This is about the about how you treat a patient, about how you treat a patient who has a gradient. Now, when do you say that the gradient is significant? Significant gradient कब बोलेंगे? अगर baseline gradient is more than 30, baseline gradient is more than 30, ये वाला, if it is more than 30, हमें कुछ नहीं करना है, ठीक है, that is significant, ठीक है. अगर अब 25, 20, 22 है, then we need to do provocative measures. Provocative measures में क्या होता है? या तो आप वुल्साल्वा करोगे, ठीक है, वुल्साल्वा करोगे. अगर अब पेशेंट वेंटिलेटर पे या बाकी चीज, मतलब if he is not able to do Valsalva, then you will put the flat of your hand on the abdomen of the on the abdomen of a patient and press it for 4 to 5 seconds और gradient ले तब तक, ठीक है. तो this is about the gradient. More than 30 gradient अगर है तो we don't need to do provocative measures. If it is less than 30, then we need to do provocative measures. I hope you have understood this. Do you want me to repeat it or have you understood it? Because I'll be asking certain questions now. Can you mute yourselves? Can you unmute yourselves, please? Dr. Pratibha. Dr. Pratibha. You asked me to repeat it. 511. Can you please unmute yourselves?
नहीं समझ गया.
Dr. Pratibha.
हाँ जी sir.
You tell me, did you understand it or not?
No sir. To be very true. Yeah.
Eh?
So I didn't understand the echo findings and the gradient variations in HOCM and HCM.
Okay. Right.
Systolic movement of the leaflet. But after
ASH
that,
you understood?
yeah.
ASH you understood? SAM you understood?
SAM I have understood.
Okay.
But
ASH
after,
and SAM are M mode findings, right?
okay, yes, true.
So, right. When you come across a patient of HCM, right, you find SAM in them, you find ASH in them, then you will need to find the gradients, right? What you will do is that in the five chamber view, you'll put the continuous wave Doppler across the LVOT, right? And if you get this type of an outline, you need to put a point on the maximum velocity here. Okay? So the machine will give you the maximum pressures, right? This is what is called the gradient. Okay? अगर ये gradient 30 से ज्यादा है, तो you don't need to do anything. If the gradient is less than 30, you need to do some provocative measures. Provocative measures में क्या करेंगे? You'll ask the patient to perform Valsalva maneuver. During the strain phase of the Valsalva maneuver, you'll again put the continuous wave Doppler across the LVOT and measure it. ठीक है? और अगर ये Valsalva के बाद 30 से ऊपर गया, then you have been able to generate gradients more than 30 after Valsalva. So that also qualifies for HOCM. ठीक है? और अगर विदाउट Valsalva gradient 30 से ज्यादा है, फिर तो establish करने की जरूरत ही नहीं है. The gradient is to establish the presence of HOCM. Only the gradient will establish or refute the diagnosis of HOCM. देखो HCM तो है ही है, hypertrophic cardiomyopathy है ही है. Now, if this patient is having obstructive part or not, that will depend on the gradient. If the gradient without provocation is more than 30, diagnosis is established. If the gradient is less than 30, but you strongly suspect HOCM, then you'll ask the patient to perform Valsalva maneuver. Valsalva maneuver उसने perform किया, and उसमें अगर 30 से ज़्यादा आ गया, then that will establish the diagnosis again. और अगर Valsalva के बाद भी नहीं आया, then that is HCM without obstruction, not with obstruction.
This we have to do in a 4-chamber view at LVOT.
No, 5 chamber. LVOT 4 chamber में थोड़ी होता है. 5 chamber में.
5 chamber.
While you are opening the aortic valve.
Aortic valve.
Right.
Okay.
या 5 chamber में, या इसमें भी एपिकल 3 चेंबर में भी. देखो ये तो एपिकल 3 चेंबर में है, जहां पे भी आपको LVOT अच्छे से दिखे और अच्छे से you are able to put a parallel beam, a beam as parallel to the LVOT as possible. Got it? नहीं अभी आगे did you understand it, Dr. Pratibha?
Yes, sir.
हाँ.
Thank you.
Gradients, you are coming across HCM, you are suspecting on the basis of SAM and ASH, your aseptic central hypertrophy, you are suspecting obstructive variant of the HCM. Then you need to measure the gradient, right? Because on the basis of gradient only you can establish a cause of obstructive pattern. If the gradient is not there, if the gradient is not significant, you cannot label it as obstructive. Only on the basis of gradient. So what you will do is रूटीन में जैसे आप एको करते हो, ठीक है, वैसे कर रहे हो आप. एएसएच आपको दिखा, सैम आपको दिखा, आपको टर्बुलेंस दिखी एलवीओटी में, ठीक है. फिर आपने डायग्नोसिस एस्टैब्लिश करने के लिए यू आर मेकिंग अ 5 चेंबर व्यू. एलवीओटी ओपन कर लिया आपने, आपको अगेन वहां पे टर्बुलेंस दिख रही है, ब्लड टर्बुलेंस. फिर आप कंटिन्यूअस वेव डॉपलर डाल दोगे और इस टाइप का डैगर शेप्ड आउटलाइन आ जाना चाहिए. डैगर शेप्ड आउटलाइन, इफ द प्रेशर इज मोर देन 30, योर डायग्नोसिस इज एस्टैब्लिश्ड. इफ the maximal pressure is less than 30, but you're still suspecting, you're still suspecting there is a high index of suspicion of obstructive pattern on the basis of ECG features, on the basis of clinical behavior of the patient, on the basis of murmur, on the basis of SAM, on the basis of ASH, then you need to ask the patient to perform Valsalva maneuver. ठीक है, Valsalva maneuver during the strain phase of the Valsalva maneuver. ठीक है, you need to again take the continuous wave Doppler across the LVOT, be it in the 5-chamber view or the apical 3-chamber view, wherever you are able to align the continuous wave Doppler across the LV as much parallel as you can. Then if you obtain a gradient more than 30, then you have been able to provoke the obstruction, and you can hold the diagnosis, you can establish the diagnosis. Obstructive hypertrophic obstructive cardiomyopathy. I hope I have made myself clear. अच्छा, ये जो 50 का था ना, यहाँ पे ये 50 का था, this is for the treatment part. This is not for the diagnostic part. This is for the treatment part. इसको तो भूल ही जाओ, ठीक है? Just forget about it. Baseline maximal pressure gradient more than 30, no need to do anything. If it is less than 30 but you are still suspecting, then you need to do Valsalva maneuver. I hope I have made myself clear. Now can you people unmute yourselves for 5 minutes? Dr. Pratibha, how will you suspect a patient? How will you suspect HCM in a patient?
So there are 4.
What will be the no? Tell me the clinical profile of the patient. How old will the patient be, and what will be the symptomatology of the patient? And before echo, the patient will definitely be having ECG in his hand. So you tell me how a patient with HCM will present to you.
The age will be probably.
Can you speak a bit louder? You're barely audible.
Age will be approximately between 45 to 55 years of age.
No, 55 तो ज़्यादा हो गया. He'll be in the 30s, 20s, 30s. ठीक है. Then
the symptoms will be dyspnea, palpitation.
Dyspnea, angina, palpitations. Very good. Then in ECG, there'll be LVH, there'll be strain pattern, there can be LAE, and there can be left axis deviation. Right. On the basis of this, because this is what you do not expect in a young individual, right? These ECG changes. Now you will suspect HCM, right? Now in the Plex view, what will you see? In a case of HCM. In a
Plex, in a HCM, if SAM will be visible on getting.
See, that is an HOCM. This is the confusion you're having.
So hypertrophy of the
In
muscle.
hypertrophic cardiomyopathy, see, HOCM is a subset of it. In HCM, there will be hypertrophy, right? There will be hypertrophy. And if it is a if it is a HOCM subset of the HCM, then there will be SAM, there will be asymmetrical septal hypertrophy, right? So you'll have hypertrophy, you can have SAM, you may or may not have SAM, and you may or may not have asymmetrical septal hypertrophy. Then the LV systolic function will be very good, right? It will be very good. It will be supranormal. Okay. Then you can have mitral regurgitation. And if it is HOCM, then you can have the pressure gradients, right?
Yes.
You got it?
Right. Yes, I got it.
Yes. So that was about the HOCM. Okay. Now, certain cardiac death in HCM most frequently in young at less than 30-35, as I was telling you right now. Primary VFVT tend to die during or just following vigorous physical activity. Often is first clinical manifestation of disease. HCM is most common cause of SCD among young competitive athletes. Okay. The risk factors for sudden death in HCM: atrial fibrillation, myocardial ischemia, LV outflow obstruction. ठीक है जी. Then this is the disease progression HCM. ठीक है. Give me a minute. In HCM, this is the disease progression in HCM. See, it can be a stable and benign course. There can be a sudden death, atrial fibrillation, symptom progression, and end stage. There are certain types of HCM wherein the prognosis is as good as normal individuals. वो वाला subset भी है HCM के patients का. ठीक है. So let's get the nomenclature right. SCD, certain cardiac death in competitive athletes, less than 35 जो होते हैं, less than or equal to 35, HCM 48% होता है. 35 के ऊपर CAD होता है 80%. ठीक है. तो 35 से कम patients, 35 और less than 35-year-old competitive athletes में 48% HCM contribute करता है to the sudden cardiac death. Now that was about the obstructive cardiomyopathy, hypertrophic obstructive cardiomyopathy. Now I will show you some slides of apical hypertrophic cardiomyopathy. ठीक है. देखिए HCM में सबसे डेंजरस जो है वो obstructive है. बाकी तो जो ये apical है ये least dangerous है. Apical hypertrophic cardiomyopathy, also it is also known as Yamaguchi syndrome. ये जापान में बहुत ज्यादा होता है. Also known as Yamaguchi syndrome. It's a rare form of hypertrophic cardiomyopathy which usually involves the apex of the left ventricle, rarely involves the right ventricle apex or involves both the pieces. देखिए ये this is the ECG pattern. See, giant T-wave inversions. Now you can see some degree of hypertrophy here. ठीक है. उतनी नहीं जितनी इससे पहले वाले में थी. Now you can see the apex. Apex is definitely dilated. Apex is definitely hypertrophied. Apex is hypertrophied. यहाँ तो ठीक ही है, इधर भी ठीक है. यहाँ से शुरू हो रहा है hypertrophy. ये देखिए, apex is hypertrophied. यहाँ तो ठीक ही है. यहाँ से हो रहा है start. This is the apex. Short axis is the apex. See how hypertrophied this is. See, you can clearly see the apex is hypertrophied. यहाँ पे इतना ज्यादा नहीं है. यहाँ से देखिए, यहाँ से कैसे हो रहा है ये. Almost apex is obliterated. This is called Yamaguchi. और ये straight pattern इसका ना बढ़िया एक ये मैं स्ट्रेन पे आपकी मैं एक ना क्लास लूंगा, डेफिनेटली क्लास लूंगा। ये इसका टिपिकल स्ट्रेन प्रोफाइल होता है। टिपिकल echocardiographic signs of apical hypertrophic cardiomyopathy include increased thickness of the left ventricle wall in the apical region. Apical region में thick होगा. Echocardiographic shape of the LV in the apical four chamber view resembles the silhouette of an ace of spades. ये इस टाइप का हो जाता है, ये इस टाइप का हो जाता है, हाइपरट्रॉफी की वजह से इस टाइप का हो जाता है। ये एस ऑफ स्पेड्स इसी को बोलते हैं। ये देखिए, ये देखिए, ये देखिए, दिस लुक्स द एस ऑफ स्पेड्स। ठीक है, ऊपर की तरफ हाइपरट्रॉफी हो गई, कैविटी जो ऊपर वाली कैविटी है वो कम हो जाती है बिकॉज ऑफ द थिकनेस ऑफ द एग्जैक्टली दिस टाइप। ये एस ऑफ स्पेड्स हो गया नहीं, दिस इज द एपेक्स will becomes almost obliterated, will becomes almost obliterated। हाँ, अब मैं जो बता रहा था इसके प्रोग्नोसिस का, unlike other variants of HCM, the prognosis of apical hypertrophic cardiomyopathy is relatively benign. The overall mortality rate of apical hypertrophic cardiomyopathy was 10.5% and cardiovascular mortality was 1.9% after a follow-up of 13.6 years. Now, this is almost as good as the normal individuals. Sudden death and cardiovascular events occur more commonly in patients with asymmetrical septal hypertrophy than those with apical hypertrophic cardiomyopathy, जो बता रहा था आपको। अच्छा हाँ, patients with highest risk for sudden cardiac death are those जिनमें जो these are the conventional risk factors, family में जिसका हुआ हो, family history, resuscitated this sudden cardiac death, more than one episode of unexplained syncope. Dr. Mohini, please mute yourself. NSVT on 24-hour ECG monitoring. LV thickness अगर more than 30 हो तो this is considered one of the risk factors for sudden cardiac death. Hypotension during exercise. अच्छा, potential additional risk factors क्या है? Late gadolinium enhancement and MRI. Apical aneurysm अगर होगा, mid ventricular obstruction अगर होगी, diastolic gradient between apical aneurysm and left ventricle atrial fibrillation and myocardial ischemia. Now, I'll share a few slides of non-obstructive HCM with you. ठीक है, ठीक है, obstructive वाला आ गया, apical वाला आ गया, and now I'll show you non-obstructive HCM. Here you will definitely see hypertrophy is there, hypertrophy यहाँ पे भी है, but जो anterior mitral leaflet है, this is no way closer to septum. See, किसी भी phase में ये septum को touch नहीं कर रहा है, systole, diastole किसी में नहीं touch कर रहा है, तो there can never be obstruction because of this, never. See, this is a laminar flow, no turbulence whatsoever, no mosaic flow whatsoever. This is a laminar flow. Somebody has not muted his or her voice. Okay. So, absolutely no chance of having any obstruction here. But you can see hypertrophy तो है, definitely है hypertrophy, ठीक है, altered pattern है myocardium का, altered echogenicity है myocardium की, there is hypertrophy and altered echogenicity. See, this is a streamlined flow. See the hypertrophy here, बहुत ज़्यादा hypertrophy है, short axis, spikes, short axis at the mid level. यहाँ पे तो VPC आ गया, ये VPC आ गया ECG में. See the contraction. See, यहाँ पे भी है हाइपरट्रॉफी, यहाँ पे भी है, यहाँ पे भी है, यहाँ पे भी है, इधर कम है। सी हाइपरट्रॉफी यहाँ पे भी है, यहाँ पे भी है, यहाँ पे भी है, यहाँ पे भी है, सारे में ही है। सी सेप्टम हाइपरट्रॉफी तो है डेफिनेटली। अब दिस इज द डायस्टोलिक फंक्शन। ये बताओगे कौन सा ग्रेड है डायस्टोलिक डिसफंक्शन का? हाँ डॉक्टर प्रतिभा, बताओगे कौन सा ग्रेड है डायस्टोलिक डिसफंक्शन का? या एनीवन? डॉक्टर पवन?
Grade 1.
दिस इज
Grade 1.
व्हाई?
A is more than E.
Very good, very good, very good, Dr. Milan.
Thank you, sir.
So, diastolic dysfunction is one of the components of HCM. ठीक है, जो सिम्टम्स HCM में होते हैं, देखिए सिस्टोलिक फंक्शन तो सुप्रा नॉर्मल है, बहुत ही ज्यादा है, तो इसमें मेन तो होता है डायस्टोलिक डिसफंक्शन। ठीक है, दिस इज ग्रेड 1 डायस्टोलिक डिसफंक्शन। वेरी गुड डॉक्टर मिलन, ये बहुत पहले पढ़ा हुआ है हमने, बट यही चीजें, ये बेसिक चीजें भूल जाएंगे तो फिर HCM का ग्रेडियंट निकालने का क्या फायदा होगा? एनीवेज, दिस इज द E प्राइम, मीडियल E प्राइम, ठीक है, और E बाई E प्राइम, E बाई E जो विच वी देखिए E प्राइम इज 4.46, रिड्यूस्ड है, 8 से कम है, ठीक है, ये रिड्यूस्ड है। E by middle E prime is 13.3. So this is a borderline pulmonary capillary wedge pressure. So we can indirectly say that left ventricular end diastolic pressure is high, is borderline. ठीक है, देखें हाइपरट्रॉफी, यहाँ पे भी हाइपरट्रॉफी है, यहाँ पे भी हाइपरट्रॉफी है, यहाँ पे भी हाइपरट्रॉफी, यहाँ पे भी है। So this is concentric variant of the hypertrophy. हाँ, अगर देखिए, सॉरी, so this is the color flow across the aortic valve। ठीक है, जब हम यहाँ पे कंटिन्यूअस वेव डॉपलर डाल रहे हैं तो वी आर गेटिंग ए वेलोसिटी ऑफ 157 सेंटीमीटर पर सेकेंड। प्रेशर ग्रेडियंट कितना है? 10 का। ठीक है, तो इसमें तो सैम भी नहीं है, इसमें टर्बुलेंस नहीं है कहीं पे, उसमें ASH भी नहीं है, तो ऑब्स्ट्रक्शन होने का तो मतलब सवाल ही नहीं होता है। बट स्टिल इवन देन मेक इट अ रूटीन टू पुट अ कंटिन्यूअस वेव डॉपलर अक्रॉस द LVOT या एओर्टिक वाल्व। ठीक है, तो आपका ये आ रहा है वेलोसिटी, प्रेशर ग्रेडियंट इज 10। ठीक है, दिस इज द एपिकल 3 चेंबर वेव। ये तो टैप्सी है, टैप्सी 1.9 इज नॉर्मल। सी दिस इज द सबकॉस्टल व्यू, यू कैन सी द क्लियर हाइपरट्रॉफी, इसमें भी है, इधर भी है, इवन जो RV है, RV भी थिक है, peripheral thickness is also more। ये तो स्ट्रेन है, स्ट्रेन इज रिड्यूस्ड, कितना है स्ट्रेन इसमें? -8.4, नॉर्मल स्ट्रेन तो -17 के ऊपर होता है। नाउ डॉक्टर मोहिनी, प्लीज अनम्यूट योरसेल्फ एज वेल, आप भी कर लीजिए।
It looks sometimes, sir, like smoke in LV.
Yes, smoke, swirling type of the blood there. That's what you call this set.
The patient is generally young athlete.
Very good.
They will be hypertrophy of the muscles.
Very good.
EF will be left ventricular ejection fraction will be decreased.
Will be?
Sir, decrease.
Supernova.
Increase में अगर HCM में? No. It will never. किसने बोला आपको? It will increase. It will be supranormal. be more in fact.
More than normal.
Then what are the variants of HCM? This I want to understand from you. What are the variants? एक तो HOCM है, ठीक है?
Obstructive, non-obstructive और anterior
Apical.
apical.
Very good. Obstructive और नॉन ऑब्स्ट्रक्टिव को कैसे डिफरेंशिएट करेंगे? ऑब्स्ट्रक्टिव में क्या क्या फीचर्स होंगे?
We will put a gradient across the LVOT.
नहीं, पहले ही थोड़ी ग्रेडियंट करोगे, पहले तो प्लैक्स पे चलोगे ना. प्लैक्स में क्या दिखेगा आपको? ऑब्स्ट्रक्टिव पैटर्न में प्लैक्स में क्या दिखेगा? एसिमेट्रिकल सेप्टल हाइपरट्रॉफी होगी, ASH जिसको बोलते हैं. व्हाट इज ASH डॉक्टर मोहिनी?
ये सही क्या होता है?
व्हाट इज ASH?
Asymmetrical hypertrophy, sir.
ASH एसिमेट्रिकल
Hypertrophy.
Septal hypertrophy.
यार S कहां से गया? S कहां गया? साइलेंट.
Asymmetrical septal hypertrophy.
हाँ, तो what is the definition of asymmetrical septal hypertrophy? When you will you call it asymmetrical septal hypertrophy? पहले तो ये M mode finding है, ठीक है? What are the criteria for asymmetrical septal hypertrophy? Septal posterior wall ratio?
More than 3:1.
More than 1.3.
1.3
sorry.
in normotensive and 1.5 in
In
hypertensive. So before you are doing
Hypertensive.
echocardiographic examination of the patient, you should ask him whether he is hypertensive as well. अगर वो hypertensive है, then ASH के criteria change हो जाते हैं. Septal posterior wall more than 1.5. अगर hypertensive नहीं है तो then it is 1.3. Please understand it. हाँ, तो प्लैक्स में तो आपने ये देखा, एक तो हाइपरट्रॉफी देख लिया आपने, ASH देख लिया, और ऑब्स्ट्रक्टिव पैटर्न में क्या होगा? और इसमें प्लैक्स में M मोड फाइंडिंग में सैम
anterior septal motion.
हाँ, systolic anterior motion.
Anterior motion.
Sam, systolic anterior motion. Systolic anterior motion of the anterior mitral leaflet. What is that? That means anterior leaflet of the mitral wall comes in contact with the septum during systole. During systole. Please understand that you have to have ECG in place while you are doing the echo to label as systolic anterior motion of anterior mitral leaflet. It will stick with the septum. This will in turn result in turbulence of blood flow across that. Right? चल के short axis में क्या दिखेगा? SP Gautam, Dr. SP Gautam.
Yes, sir.
What further will you anticipate in a case of HCM? चलो प्लैक्स तो हो गया, सैम देख लिया आपने, ASH देख लिया आपने, शॉर्ट एक्सिस में हाइपरट्रॉफी होगी, उसके बाद क्या देखोगे? और when will you establish the diagnosis of HOCM?
Gradient देखेंगे सर.
हाँ, ग्रेडियंट कैसे देखोगे? कहाँ पे?
Aortic LVOT level पे.
हाँ, 5 चेंबर में, 5 चेंबर बना के, हाँ, you'll put a continuous wave Doppler
As perpendicular as possible to the flow.
yes, as parallel as possible. तो उसमें क्या देखोगे आप?
Gradient देखना सर basically.
हाँ, नहीं तो what is the shape of the gradient, the profile?
Shape.
It will be dagger shaped.
Oh, sorry, dagger shape. Yeah.
It will be dagger shaped. It will never be rounded. If it is rounded, then वो AS का है.
AS का.
हाँ, हमने एक मुझे याद है, आप लोगों को मैंने दिखाया था एक बार, जो PS और सिवियर PS था, और उसी पेशेंट में इन्फेंटिबुलर स्टेनोसिस भी थी. उसमें 2 डिफरेंट टाइप्स के आपको मैंने वो दिखाए थे, वो प्रोफाइल्स दिखाए थे. एक डैगर शेप्ड था और एक राउंडेड था. हाँ, तो दिस हैज टू बी a dagger shaped, right? This has to be dagger shaped because dynamic obstruction है, तो it will be dagger shaped. It will never be smooth. ठीक है? तो when will you say that the gradient is significant?
More than 30.
मोर देन 30। अगर अब सारे फीचर्स हैं, ASH भी है, सैम भी है, सारे फीचर्स हैं और ग्रेडियंट आपका 20 आ रहा है, फिर
प्रोवोकेटिव के लिए जाएंगे।
प्रोवोकेटिव के लिए जाएंगे। वेरी गुड, प्रोवोकेटिव के लिए जाएंगे आप
आस्पोर वैल्सल्वा,
वल्साल्वा, हाँ वल्साल्वा करेंगे। वल्साल्वा स्ट्रेन फेज ऑफ द वल्साल्वा, राइट? You should say there are few phases of the वल्साल्वा maneuver. So strain phase, जहां जिस टाइम वो सांस छोड़ रहा होता है अगेंस्ट द क्लोज ग्लॉटिस, ठीक है, तो होल्ड कर रहा होता है जब वो, तो दैट इज द स्ट्रेन फेज ऑफ द वल्साल्वा। तो that will establish the gradient, that will reveal a hidden gradient sometimes, ठीक है। कभी किसी ने मेडिसिन ली होती है या कोई मेडिसिन ली होती है तो उसमें उतने ग्रेडियंट नहीं आते हैं उस टाइम, ठीक है। तो अनकवर दोस ग्रेडियंट्स, टू रिवील दोस लेटेंट ग्रेडियंट्स, यू नीड टू, we will ask the patient to perform Valsalva maneuver. अगर वेंटिलेटर पे है तो we'll put the flat of our hand, press it firmly on the stomach, ठीक है, on the abdomen, तो उससे भी ग्रेडियंट आ जाएगा। अच्छा, मान लीजिए अब इसके बाद ग्रेडियंट आ गया मोर देन 30, तो एस्टेब्लिश हो गया डायग्नोसिस। अगर नहीं आया ग्रेडियंट, तो अगर ग्रेडियंट 15 के 15 रहा 20 रहा, तो विल यू से दैट दिस इज HOCM? No. Very good. You will label HOCM on the basis of gradient only, right? Okay. Now about the apical HCM is also called Yamaguchi, mostly found in Japan and Chinese population. Prevalence वहां पे even 13 to 15% है population, यहाँ पे कम है, but we have reported some cases. तो उसके बाद है concentric HCM या नॉन ऑब्स्ट्रक्टिव HCM। नॉन ऑब्स्ट्रक्टिव HCM ही, अच्छा हाँ, अब डॉक्टर मोहिनी, you will tell me the difference between HCM and athlete heart.
Sir, in HCM the hypertrophy will be asymmetrical, and in athlete there will symmetrical hypertrophy. LVE ejection fraction.
Can you just repeat it again? What did you say? Athlete heart and HCM.
HCM. So in HCM there will be asymmetrical hypertrophy, but in athlete there will be.
अच्छा हाँ, बस ठीक है, हाँ हो सकता है, हाँ। और
and so the systolic function will be increased in HCM, but it will be normal in athlete heart.
Okay. और main क्या है? Diastolic function?
Diastolic function will be.
Main तो वही है, वही तो skip कर रहे हो आप। Diastolic, there will be diastolic dysfunction in HCM, but it will be normal in athlete heart. Or LA dilatation can be there in HCM, but LA will be normal
in athlete heart.
ठीक है, तो ये हो गए, ठीक है। अब मेरे से ये पूछें कि just ask me if there is anything you didn't understand today.
So should we keep the criteria of LVOT obstruction for 30 or 50?
No. मैंने आप ना वो जो 50 वाली है ना, वो तो निकाल दो दिमाग से आप, ठीक है। That's for the treatment purpose. That is when to treat.
That means we need to diagnose. If we need to diagnose that, then we have to think of 30, and if we have to treat the patient, then we have to think of 50.
Yes, that is 30. That see, for holding or refuting the diagnosis of HOCM, 30 is the criteria. And when we are treating the patient, if the patient is symptomatic and on baseline his maximal pressure LVOTO is more than 50, then he straight away has to undergo myomectomy या
ablation or myomectomy.
हाँ.
So are we not going to treat a patient with 30 of gradient with symptoms.
नहीं, ट्रीट तो करना है ना उसमें
नहीं, एब्लेशन नहीं करना है.
एब्लेशन देखिए, वैसे पेशेंट्स में यू नीड टू पुट द पेशेंट ऑन बीटा ब्लॉकर्स, ठीक है, मैक्सिमल डोज ऑफ बीटा ब्लॉकर्स. यू विल ट्राई टू अटेम्प्ट अ हार्ट रेट ऑफ 50 to 60, ठीक है. अगर उसके बाद भी डिस्पाइट ऑन बीटा ब्लॉकर्स द पेशेंट इज सिम्प्टोमेटिक. अच्छा, अब तो ट्रीटमेंट दो टाइप के हैं इसमें, ठीक है. एक तो आपको ऑब्स्ट्रक्शन रिलीव करनी है, ठीक है, और दूसरा आपको सडन कार्डियक डेथ प्रिवेंट करना है. समझ रहे हैं आप? तो सडन कार्डियक डेथ, बस ये भूल ना करें आप कि जो सडन कार्डियक डेथ है वो बिकॉज ऑफ ऑब्स्ट्रक्शन होता है. नहीं, सडन कार्डियक डेथ occurs because of arrhythmias, although patients who have obstruction have more chances of sudden cardiac death, but it can occur in independent of the obstruction, ठीक है. अदरवाइज तो फिर नॉन ऑब्स्ट्रक्टिव पैटर्न में तो होना ही नहीं चाहिए था सडन कार्डियक डेथ. तो उसके लिए जो ट्रीटमेंट है सडन कार्डियक डेथ अवॉइड करने के लिए वो है आईसीडी, ठीक है. और ऑब्स्ट्रक्शन रिलीव करने के लिए देयर इज पहले तो मेडिकल थेरेपी. यू नीड टू गिव मैक्सिमल डोज ऑफ बीटा ब्लॉकर्स. यू नीड टू अटेम्प्ट, you will attempt a heart rate of 50 to 60. Then if it doesn't get relieved, then you'll go for alcohol ablation or myectomy, right? But those patients who are symptomatic, have initial gradients more than 50, they will straight away go for this. Got it? हाँ, देखिए ये दिस इज द पल्स वेव डॉपलर अक्रॉस माइट्रल वॉल, ठीक है. इसमें दो तरह के प्रोफाइल आते हैं. ये इनिशियल फीलिंग वेलोसिटी है, ये लेट फीलिंग वेलोसिटी है. इनिशियल फीलिंग वेलोसिटी, अर्ली वेलोसिटी, इसको ई बोलते हैं और इसको ए बोलते हैं, ठीक है. समझ रहे हैं आप? जो ई वेलोसिटी यहाँ पे 59.2 है, ठीक है. नाउ this is the tissue velocity, right? This is the tissue velocity. Tissue velocity में भी सेम है E A, बट यहाँ पे E प्राइम लगाया जाता है. E प्राइम A प्राइम. E प्राइम इज कितना है? 4.4, ठीक है, 4.46. तो जो यहाँ पे E था 59 डिवाइड बाई 4.46, इसका जो रेशियो है इसको बोलते हैं E by E प्राइम, which roughly reflects the pulmonary capillary wedge pressure या left ventricular and diastolic pressure. So this is 13.3. This is borderline. Above 14 is above 14 is raised. तो 13.3 is ये भी मतलब borderline है, raised ही है or not? Okay. Again same यहाँ पे देखिए, ये डायस्टली के दोनों वेव्स डायस्टली में है. जो पहले आएगी वो ई है, जो पी के बाद आएगी वो ए है. Got it?